I would like to thank the organizer. I would like to thank also ESG. Yes, we are used to work with the system and computerized system with capsule, but unfortunately, the small bowel is a quite strange environment. And as we will see in the next few slides, we are still some steps behind what we are used to do with artificial intelligence in colonoscopy and gastroscopy, for example. This is my conflict of interest statement. Why are we talking about artificial intelligence specifically in the field of capsule endoscopy? This is the main reason. Because we are literally overwhelmed by thousands of images when we are dealing with capsule. Those are 2,000 images, but when we are looking to a video, we are normally dealing with more than 50,000 to 90,000 images. We have to check every single image, we have to incorporate all the data, we have to elaborate it, and our goal is to find out significant findings that might appear only in few frames. So it's like looking for a needle in a haystack. And that's our task when we review a video. And for that reason, we are spending time. I mean, between 30 and 120 minutes for every single video. It requires time, it requires dedication, it's a quite long process. Someone defines that tedious. It requires undivided attention. And there is another reason why artificial intelligence is a fertile ground for capsule. Because it's unlike gastroscopy or colonoscopy. Once we acquired our data are there. When we download the video is inside our workstation, we can process it, we can use it a lot of different kind of algorithms to test it and to check what's within the video. I'm sorry. What we expect from artificial intelligence in capsule from a practical point of view. From a practical point of view, we expect that we can have a system which is able to quantify the level of cleansing. As we know, there are a lot of scales in capsule, but all of them requires time. For all of them, you have to calculate the amount of surface which is covered by debris and so and so it requires time and is highly subjective. The second point is to evaluate where the landmarks, where the anatomical landmarks are, because that influences the position of the lesions along the small bowel, and it influences the next step in the management of patients. For example, if we have to plan a device-assisted enteroscopy, we have to decide if we have to go for an anal route or for an oral route or so. But the most important task we are looking for in capsule endoscopy right now by artificial intelligence is for sure lesion detection. As I said at the beginning, we are a step behind compared with gastroscopy and colonoscopy in the field of capsule, because as we'll see, it's not so easy to accomplish this task by AI. Anyway, what we expect for AI is to be so highly performant to make any kind of reviewer able to depict all the lesions as an expert, and to do that task in a quite short interval of time. As Costa said at the beginning, we are used to work with AI in capsule endoscopy, but so far there are two, let's say, families of reading support software models. The first one, the oldest one, is based on the image selection and elimination. What does it mean? It means that the system is able to recognize that there are similar images, one close to each other, and it's able to select just few of them. So you are reducing the burden of the images you are looking at. So you are reducing the time you are spending for doing that, but you have to remember that this applies to normal images, that's okay, and applies also to pathological images. So by doing so, theoretically, you are reducing the burden of the haystack, but you are making your needle even smaller. So sometimes you can lose images just because they are reducing in number. So what we are looking for, and that brings us to the second family of possible reading support software models, is the combination of these passive image selection and elimination, together with an active system which is able to actively identify lesions. At the present time, there are only two companies producing those kind of softwares, including those kind of softwares in the product which are available in the market. This is one of those. As you can see in the next few seconds, there will be an indicator here which is running through the color bar quite fast, because this is the fact of the elimination, because we are reducing the number of images we have to look at. But at the same time, there will be some bounding boxes as you can see here. We are activating the system. The system is running very, 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 very fast compared to a regular view, but there are also those bounding boxes there. We are used to that kind of layouts for colonoscopy, for gastroscopy, and so, which is attracting our attention to the point where potentially a lesion is. Is there any data about that? Yes, there are, of course. This is the first published study. It's a Chinese study published in 2019. It was, let's say, much more technical than clinical. And by doing that study, the authors were able to demonstrate that by using AI, the sensitivity and specificity in lesion detection was really high, comparable with that of experts and the panel of experts, which was the reference standard in this study. And most importantly, they also show that when you are dealing with a long video, which is about 500 minutes, if you do a regular video evaluation, which means a standard view, you are spending about 1 hour and a half. But with the same sensitivity, with a high sensitivity and high specificity, you can do the same kind of task by using AI in less than 6 minutes. That means sparing a lot of time. This is another study. It's not yet available in full. It has been presented during the last ESG days and during the last DDW. It is a study which has similarities to the previous one, but it has a very, very strong methodological construction, meaning that it's the multi-center, blinded, prospective, non-inferiority study, and is also a clear focus from a clinical point of view, because it's selecting consecutive patients with suspected small bowel bleeding. And the authors also build up a very strong reference standard, which was a central reading. They demonstrated with that study, by including 133 patients, then when we are focused to P1 and P2 lesions, for those of you who are not familiar with the P1, P2 classification, which is the Soren classification for capsule endoscopy. P1 and P2 means that we are addressing lesions with a very high potential of bleeding, P2, and lesions with intermediate risk of bleeding, P1. That's the way in which we describe those lesions with capsule, since we have to provide a sort of risk of bleeding for every finding we are identifying. So focusing on those two kinds of lesion, the diagnostic yield by using AI was significantly higher, 10 points higher than the standard view. And by comparing the AI review with the reference standard, the sensitivity and the specificity were very high. But as you know, there is a major criticism for AI in the field of detection, generally speaking, and specifically in the small bowel. I mean, AI is trained to show and to select everything which is not normal, which looks different from the normal tissue. So sometimes it's bringing to our attention a lot of images. We are normal variants, for example, or which are not significant at all from a clinical point of view. And this can have a detrimental effect. So the authors focused on a per lesion analysis, and they showed that focusing still on P1, P2 lesion, by using AI, there is an increased number of those lesions which are clinically significant lesions. And even if we are focusing on P2 lesions, the P2 lesions are those lesions we would not miss during the evaluation, because those lesions have very high potential of bleeding. And generally speaking, those lesions are much more prominent, much more easy to be identified. So by even focusing on those lesions, there is still a delta, which is smaller compared than before, but there is still a significant difference here, meaning that when you are using AI for your supporting reading capsule, you are picking up even much more significant lesion, and not only less significant or non-significant lesions. And you can do that by sparing time, meaning that instead of spending 33 minutes for reviewing the small bowel, you are spending 3 minutes, 10 times lower. And similarly, when you are looking at the entire video, including stomach and colon, you are spending 7 times less time compared to the standard view. There are also other data coming out. This is a Chinese study. It's very huge, more than 5,900 videos, if I remember correctly. And this is a validation study. It means that this is a step behind compared to the clinical studies. But they included also a tentative lesion characterization. There are no specific data about that in that study. There are just some pictures and some informations. So we expect new data about that possibility not only of depicting a lesion, but having also a label close to the lesion, which is showing us which kind of lesion we are facing. This is another study. This is a European one by Deidre McNamara. They use the same system, which is the second one by another company, and they demonstrated similar results in terms of detection, but they also show that there are possibilities of evaluating automatically the cleansing, and the system was extremely reliable when characterizing a video as adequately or non-adequately prepared. Those are very good news for us, because instead of sitting in front of a computer for half an hour, an hour and a half, I can spend only 6 minutes for reviewing a video. But there is also some issues we have to take in mind, because not all that glitters is gold. First of all, because in the field of capsule, there is no independent reference standard. I mean, when you are comparing a new technique with a reference standard, theoretically, the reference standard has to be outside the technique itself. Otherwise, you are sharing the same kind of biases. That's not the case of the capsule, because the reference standard in the field of capsule is represented by the panel of experts. There are no independent data coming for that kind of information. As Alana said before, for gastroscopy, colonoscopy, for Barrett, you have histology. Okay, histology is not as gold as we think about, but is still something much more reliable than a panel of experts evaluating the same kind of video. And you have to take in mind also there is another point. We cannot suggest, even for ethical reasons, to perform device-assisted enteroscopy in all patients receiving capsule endoscopy, even in case in which is negative. That would be the case of having an independent reference standard, but it's not possible from a practical point of view. There is another point about the reference standard. If our reference standard is the panel of experts, when we are looking at intra and inter-observer agreement by experts, this is good or perfect in less than 1/4 of cases when we are looking at inter-observer agreement. And even when we are looking at intra-observer agreement, meaning that there is the same readers who's checking the same video after a period of time, a washout time, here, even if the same reader, the intra-observer agreement is far behind from what we expect from a reference standard. There is another point, as Alana mentioned before, if you would like to have a strong and reliable outcome from AI, we have to provide a lot of information, annotated or not, but we have to provide a lot of information, and those information has to be as high quality. But unfortunately, it does not apply to difficult lesions. I mean, for example, for those of you who are familiar with the capsule, submucosal lesions are very difficult to be identified. And when we are looking at those kind of images, what we are providing now to the system is the delineation of that area, which is the pathological one. But we have to provide thousands and thousands and thousands of those kind of images to teach correctly the machine to do its own task. And unfortunately, we don't have this. So what we do in real life, what we do is this one. I mean, not focusing on a single image, but focusing on a sequence of images and just comparing one to the other one. Here there is something because the capsule is not moving. Here there is something because the folds have a different kind of shape. If there is something because probably there are little tiny changes compared to the surface. So you just by integrating all those information that we are able to come out with a diagnosis. So my feeling is that if we are dealing with difficult lesions, those who are difficult right now will be even more or equally difficult even with the artificial intelligence. And personally speaking, I would like to have an artificial intelligence who helps in this task instead of finding out a more additional arteriovenous malformation, which is a quite common finding in capsule endoscopy. There is no time, unfortunately, for addressing this point, but I don't really know why, because personally speaking, I think that it's quite easy to identify the point of passage of the capsule through the pylorus and through the ileocecal valve, but the data so far we have are absolutely, machines are absolutely not reliable in that task. And so even if they are providing you a suggestion, please check it twice, because that's your final judgment that will be probably the right one instead of those provided by the machine. As I mentioned before, the majority of data we have so far are data about validation, about single image evaluation. They are strictly focused on one single kind of lesion. For example, algorithms for bleeding, algorithms for masses, algorithm for ulcers, but multi-class softwares needs for sure large multicentric study which are not available yet. There are also some legal and cost-effective issues as for any kind of system. So in conclusion, I sincerely think that for capsule endoscopy, the future is really now. I mean, capsule and AI can go together and they can change our way of looking at lesions and our way of reading capsule endoscopy videos. But there is still a lot of work to do because this is a quite specific environment which is completely different when compared to gastroscopy and colonoscopy. Many thanks for your attention.